Uh, Good morning. Welcome to this poster podium presentation on Neuro-Ophthalmology. We have 4 minutes allotted to each presenter, followed by 1 or 2 questions. Okay. So I think without any delay, we can start our presentation. All the best for all the presenters. Welcome. Okay, it's a bit early also today morning. Hope everyone has come very early to present. So please, the first speaker will be Dr. Maitri. She'll be presenting on descriptive study on the clinical profile of compressive lesions of the optic chiasm. Meanwhile, the next presenting author will be Dr. Lokesh Jain. I think he's there. Is he there? No. I think the next presenting author will be Hemant Ramchandar. Is it? Yeah, fine. Yes, Dr. Maitri.
Good morning, everybody. I'll be presenting a study on the clinical profile of compressive lesions of the optic chiasma. So we have no financial disclosures. We all know that cellular or supracellular tumors can cause compression of the optic chiasm, but they could be asymptomatic or present to us with varied visual symptoms, varying from mild or moderate loss of visual acuity and visual field to very severe loss of fields and visual acuity. So we need to have certain parameters or certain indicators to look for early diagnosis and to analyze the prognosis of such patients to prevent further loss of vision. Our purpose in this study was to analyze the demographic profile, the causes, find out the clinical features, and some prognostic indicators to know what could lead to severe visual impairment. It was a retrospective study of 136 eyes in 68 patients with cellular or supracellular lesions taken in a course of 2 years. We assessed their detailed history, the visual acuity, color and contrast sensitivity, RAPD assessment, visual fields, the OCT of the retinal nerve fiber layer as well as the macular ganglion cell complex. Their MRIs were looked into, whether they underwent neurosurgery or not, and whether they scheduled for it or not was looked into, as well as their fundoscopy was done. We found that there was no sex predilection. All of them, whether they were male or female, had equal chances of getting it. And a majority of them belonged to the younger adult group, 31 to 40 years. Most of them had good visual acuity, say 6/9 or better, and very few of them, hardly 10%, had lesser. But color vision was abnormal in about 11% of the patients. RAPD could be seen in about 14% of the patients, and disc pallor, which was noted in 38 to 40% of the patients, only after prolonged compression is what we realized. So most of our patients had pituitary macroadenoma, which is known to be the most common cause of chiasmal compression. Others had craniopharyngioma and Rathke's cleft cyst. We did not have patients of other conditions. And the most common visual field defect in our study was a bitemporal hemianopia. But it should also be noted that we did have other field defects presenting to us, like a homonymous hemianopia, quadrantanopia, an enlarged blind spot, constriction of the generalized visual fields, as well as a central scotoma. We did an optical coherence tomography for all our patients, assessing the retinal nerve fiber layer thickness as well as the macular ganglion cell complex. Because of the retrograde axonal degeneration, there would be thinning of RNFL and GCC. And it shows that the loss of nasal ganglion cell complex reflects on the bitemporal hemianopia that is seen. And in case of patients where visual fields are not predictable or reliable, we can always look at the GCC to make out whether they have compression or not. So in our study, the signs of chiasmal compression were reduced visual acuity, reduced color vision and contrast sensitivity, relative afferent pupillary defect, optic disc pallor. And all of these can occur after prolonged compression or in patients in whom the lesion is pretty large or compressing a lot. But the thinning of the retinal nerve fiber layer and the loss of macular GCC could be seen at earlier stages as well in patients where none of the above parameters were seen. So our study demonstrates that pituitary tumors are the most common cause, of which pituitary macroadenoma is the most common cause, while visual fields can be caused by multiple pathologies like direct compression or as a ripple effect or because of previous impingement or vascular shunting. What was known till now was cellular or supracellular tumors can cause chiasmal compression and that bitemporal hemianopia is the most common field defect. But you should also look out for atypical field defects which should not be overlooked in an enlarged blind spot or homonymous hemianopia can also be because of this when the tumor is larger or is extending either anteriorly or posteriorly. And like I already mentioned, the loss of nasal macular GCC on the OCT shows the bitemporal field effect because the nasal fibers from the macula go to the optic nerve on the nasal side and then decussate to the temporal side of the contralateral tract. So with this, we can assess the immediate need for treatment, talk to the neurosurgeons and tell them that there is already compression. So the patient needs to be treated either surgically or medically so that there's no further loss of vision. So early detection of the compression through visual field testing and OCT can aid in quicker treatment and prevent further loss of vision. Thank you.
Thank you, doctor. Actually, I have one question. Do you have any associated, all these cases were proven cases of chiasmal tumors?
Yes, ma'am. All of them MRIs were done.
Had you done in cases of pituitary microadenoma, not macroadenoma, so that you can detect the early progression?
Yes, we did have a few cases of pituitary microadenoma. We did not include them in this because when we look at the MRIs, the size of the tumor was not enough.
When you have a classical field defect, the GCC, nasal GCC is going to get affected in compressive lesions.
Yes.
When you don't have any field defect, your RJC is going to give you a clue whether there is a signs of early compression or not.
Yeah.
Did you have any case of acute onset nystagmus in these cases?
No, none of our patients had.
None of our patients. Any diplopia?
No, none of them had any diplopia or strabismus or any other signs there. These were the only signs we found in our study.
You have any questions?
Right, yeah.
Thank you.
Thank you.
We call upon the next speaker. Next speaker is Dr. Lokesh Ji. Yeah. He'll be presenting on 2 rare cases of CRAO with a total ophthalmoplegia following spinal anesthesia.
Can you give a bell after 3 minutes? Because I think we also didn't make note of it. The presenting person can also have, he can wind it up in the 1 minute. Yes, doctor.
Just give bell after 3 minutes.
You give a warning bell, fourth
Warning
bell
bell
is for
after 3
completion.
minutes.
You give after 3 minutes, they will know that they have only 1 more minute to present.
Respected chairpersons, in my dear colleagues, I will be presenting on 2 rare cases of CRAO with total ophthalmoplegia following spinal anesthesia. A central retinal ocular occlusion is an abrupt diminution of blood flow through central retinal artery severe enough to cause ischemia of the inner retina. CRAO is a rare event. It has been estimated to account for only 1 into 10,000 outpatient visits to the ophthalmologist. Van Graaf in 1859 was the first to report the case of patient who experienced an acute CRAO. Visual loss and ophthalmoplegia are very infrequent complications following spinal surgery. Visual loss may be caused by ischemic optic neuropathy, central retinal artery or vein occlusion, or occipital stroke. Ophthalmoplegia after spinal is even more unusual than visual loss, and only few reports exist in the literature. I'll present one case. A 40-year-old full female presented in our OPD with chief complaints of decreased vision and pain in the right eye from last 6 days. She gave a history of cholecystomy under spinal anesthesia 15 days back. There was no previous history of any ocular disease. There was no history of diabetic hypertension or other systemic illness. Her fasting or blood, post-spinal blood sugar were within normal limit, and ECR was also normal. On examination, her visual acuity in right eye was there is no perception of light. Visual acuity in left eye was 6/6. Her right eye had ptosis and ocular movements were restricted in all the gazes. Pupil was fixed and dilated. The anterior segment slit examination was normal in both the eyes. Front examination of the right eye revealed CRAO with chariot spot at the macula. Front examination in the left eye was within normal limits. This is a picture showing the ptosis and the chariot spot at the macula. Another case was a 70-year-old male who presented in OPD with same complaint of decreased vision and pain in the right eye from last 4 or 5 days. He gave a history of cholecystomy under spinal anesthesia 3 weeks back. Patient was a known diabetic from last 5 years and was an oral hypocalcemia. His fasting and PP were uncontrolled. There was no history of any other systemic disease. On examination, there is no light perception in the right eye, and visual acuity in the left eye was 6/12. His right eye had ptosis and ocular movements were restricted in all the gazes. Pupil was fixed and dilated, and the segment was normal in both the eyes. Front examination of the right eye revealed CRAO with chariot spot at the macula. Fundus on the left eye was within normal limits. This is a picture showing CRAO in the right eye. Coming to discussion, the increase in intraorbital pressure associated with hypertension, shock, anemia, prolonged operative time, and bradycardia are considered to be the main risk factors for developing CRAO and ophthalmoplegia. In a case study by Little, 27,930 cases of controlled hypertension and anesthesia found only 3 cases of CRAO. Ophthalmology related to spinal surgery is also an exceptional complication. West et al. Declares as patient who had developed unilateral ophthalmoplegia and unilateral vision loss following scoliosis surgery. In conclusion, I would like to say CRAO and ophthalmology are unusual but a severe complication after spinal anesthesia. We came across 2 such cases within a short span of 1 week. This led us to a review of literature, but thorough search could not lead to any report presenting such picture following spinal anesthesia for cholecystectomy. Thank you.
What kind of a cholecystectomy was this? Was this a laparoscopic one or was this the open one? Because
Open one. Open spine.
It is open.
Yes.
It was not a laparoscopic
No,
one.
no,
Because
no.
then you get raised intraocular pressure also. So what made you think that it's just the spinal anesthesia which is the cause
But actually,
of
it is basically 2 patients were presented within a short span of 1 week. So that only led us to think about why the 2 patients come and both the
maybe
cases.
positioning and both the eyes, it was the right eye.
Right.
So maybe the positioning of the patient during the surgery,
Surgery.
or some other associated factor
Factors.
along with the spinal.
Maybe this is open to discussion because nothing else. Because one patient was diabetic, other patient was totally normal. She has no other systemic complaint. Nothing was there.
That could be one of the reasons, but then there was other reasons also which should be looked into as to why this happened.
I would like to clarify one thing. When do you call that vision loss attributed to the spinal anesthesia due to spinal, because there is one entity you have the perioperative vision loss following any procedure, following you have a vision loss. So the second patient was 3 weeks after, I think,
yes, ma'am.
because I think there is a time duration. I'm not very sure when you can attribute it to the anesthesia. I don't think after 2 weeks or 3
When the
weeks.
second patient, he reported after the first patient immediately reported when she had this complaint.
Right,
Second
but-
patient reported little bit late. He was a referred patient, so he was
Because after
some
3,
days.
immediately after spinal, you can take it as, but after 3 weeks,
3 weeks,
and you have a cherry red spot, I think the duration may not sometimes fit into it.
Because you cannot find the exact causal effect
Yes.
is spinal anesthesia. How
Have you
can
done?
Ethical issue should it.
many
That's
things.
Why, that's why I said it is open to discussion.
You haven't found any embolus. You haven't found any embolus.
No, sir. No, sir.
Because spinal anesthesia usually in prone position.
Yes, sir.
That the madam was saying immediately or perioperatively the vision losses, because neurosurgeons, they are operating in a prone position the spine surgeries.
Yes,
so
sir.
in those cases they are reported.
Chances are more,
and
so-
it is mainly PION.
Yes.
And 15 days that the madam says 3 weeks. It's not a relation with the surgery.
Have you done an MRI brain and orbit in this patient?
No, sir. Because one of the patient expired after 1 week, and second patient.
Vasculitis,
So you haven't
workup,
done-
or any cardiovascular, any other systemic
First patient's
association?
cardiovascular, everything was normal. Sir. MRI and all, everything was okay. There's no. Thank you.
Okay, thank you. Next, we have Dr. Hemant Ramchandar, who will be presenting on presumed capacitabine-induced optic neuropathy and maculopathy, a case report.
Good morning, everybody. Today I'll be presenting a case of presumed capacitabine-induced optic neuropathy with maculopathy. The background of the study: the incidence of chemotherapy-associated ocular toxicity is on the rise with the advent of newer chemotherapeutic agents. So actually, the use of multiple drugs along with the radiotherapy sometimes makes it very difficult to interpret this, the toxicity of these drugs. So actually, the quality of life in these patients will be further compromised due to the poor vision, making the situation a bit more worse. So we hereby report such case of presumed chemotherapy-induced optic neuropathy and maculopathy in a patient who was on capacitabine for colon cancer. So like, and then coming to the case history, a 32-year-old female who presented with sudden onset painless blurring of vision in the left eye for the past 15 days. And then there was no history of any flashes of floaters, and there was no history of any limb weakness or fever, and there was no history of any transient obscuration of vision. And then she was a known case of carcinoma colon, and then who was on actually capacitabine. She had already completed 3 cycles by now. So actually no other known systemic comorbidities. Then coming to the examination, the general physical examination revealed significant pallor. And then coming to the examination of the right eye, the vision was 6 by 6. And then the pupils were actually 3 mm. The direct reflex was brisk, whereas the consensual reflex was sluggish. So and then coming to the examination of the left eye, so actually the vision was actually 6 by 9. And then the pupils revealed 4 mm. Grade 1 relative afferent pupillary defect was noted. And then the IOP was within normal limits. So and then coming to the posterior segment, the right eye fundus was within normal limits, whereas the left eye, the disc was hyperemic, and then there was infero-nasal and infero-temporal disc margins were blurred, and then the CDR was not made out, and then there were few pigmentary changes which were noted at the macula. Like so, and then since there was relative afferent pupillary defect which was associated with optic disc edema, like we went ahead with optic nerve function test. First is the color vision, which was done by Ishihara chart. The right eye color vision was within normal limits, whereas the left eye red green and blue yellow defect was noted. So and then the contrast sensitivity, which was done by Pelli-Robson chart, and the right eye it was normal, which was 1.70, and the left eye it was 0.65, which was decreased. Like so, and then the OCT macula showed significant foveal thinning in the left eye. Like whereas the pattern VEP of both eyes was within normal limits. So and then the MRI brain and orbits did not reveal any active optic neuritis or any infiltration of optic nerves. So and then we came to the working diagnosis of actually capacitabine induced optic neuropathy with maculopathy. So and then we had sent a medical oncology review to change the chemotherapeutic agent. So actually it was changed like so, and then at around actually 1 month follow-up, the visual acuity in the left eye was 6 by 6 parts. So and then the pupils were reactive to light, and then the fundus was showing resolving disc edema. So like, and then coming to the discussion, in the present era, the newer advances in chemotherapy has been a boon to the cancer patients, but there is a concomitant rise in the unheard adverse effects as well. So actually some of the well-known adverse effects are in the leukemic patients, which will be infiltrative optic neuropathy and also the retinopathy of blood disc rays. So actually there are very few reports of optic neuropathy associated with cytarabine and daunorubicin, and then the maculopathy which is associated with hydroxychloroquine and desferoxamine. So actually there is very rare reports of optic neuropathy and also maculopathy coexisting like in the same patient on chemotherapy. So and then my conclusion will be the optic nerve toxicity associated with the chemotherapeutic agents has been reported in rare instances. Like here actually the ocular the complications in these patients are usually neglected. Like as a systemic condition will gain the priority. So like the early detection, proper examination workup, and timely stoppage of the causative drug will help in limiting the structural damage, functional disability, and will lead to a better quality of life. So actually oncologist and the ophthalmologist can work in harmony to facilitate the early referral and preventing the irreversible ocular toxicity. Thank you.
You haven't shown the OCT. After that, the vision has recovered, the macula OCT. And have you done the RNFL also? Because your pattern VEP was normal, color vision was decreased, and contrast sensitivity was decreased. And you have shown the OCT, because the fundus picture is almost the same that you have shown that before stopping the drug and after stopping the drug. So I think OCT picture would have been, because so much thinning at the macula and vision regaining to 20/20, and it was not that much decreased 20/30.
Did you give IV steroids?
No, ma'am, we didn't give IV steroids.
Fine. You just
Slightly, we
withdrew-
just actually changed this actually chemotherapeutic agent. So and then we didn't give any steroids.
Review of literature with this drug. Any reports with vision loss?
Like no, ma'am, actually with this drug, actually as such, there is no literature. So like with actually some other drugs like donoribicin
But
and
why the
acetaminophen.
macular toxicity? Any idea?
Ma'am?
The macular toxicity, because you have shown affection of the optic nerve as well as the macula.
Yes, ma'am.
That's why, as sir said, the
OCT.
repeat OCT would have given you a clue. Thank you, doctor.
Thank you.
For an interesting case.
Now we call upon Dr. Ashwini Guge to present on cortical blindness in COVID-19 pneumonia, a rare case report.
Good morning, everybody. Today I'll be presenting cortical blindness in COVID-19 pneumonia, a rare case report. The WHO declared the outbreak of COVID-19 global pandemic in March 2020 after widespreading of COVID-19 pneumonia cases. At the beginning of the pandemic, many physicians reported cases of conjunctival congestion and irritation in Wuhan, China. It has also been reported, in addition to the respiratory tract infection systems, patient can also have neurologic signs and symptoms like acute cerebrovascular disease, polyneuritis, encephalitis, and encephalopathy. In this report, we describe a patient who had bilateral cortical blindness as the presenting feature of COVID-19 related pneumonia. The case report, a 56-year-old diabetic male presented with the chief complaint of bilateral sudden painless vision loss associated with fever and cough since 2 to 3 days. On examination, both eyes were pseudophakic with visual acuity of light perception and PR was accurate in both the eyes. Pupils were round and there was no RAPD. Intraocular pressures were within the normal limits and other anterior segment was normal. Fundoscopy showed mild NPDR changes. Patient had mild altered sensorium and vitals were stable. MRI brain orbit showed acute non-hemorrhagic infarct in bilateral occipital lobe adjacent to the midline, suggestive of posterior circulation basilar artery or PCA territory infarct, intraparenchymal hematoma in the right frontal lobe. HRCT showed irregular and patchy ground glass opacities with intralobular septal thickening. COVID test was done and patient was RT-PCR positive. CSF, there was no pus cells or organisms. CRP was raised. There was raised serum ferritin and D-dimer levels and patient had raised RBS level. MRI picture showing acute non-hemorrhagic infarct in bilateral occipital lobe adjacent to the midline and intraparenchymal hematoma in the right frontal lobe. Irregular and patchy ground glass opacities were present in the intralobular septal thickening. Fibrocalcific changes were noted. The patient was immediately shifted to the COVID-19 setup and was managed there with antiplatelets, statins, IV antibiotics, IV dexamethasone, vitamin C and zinc supplement. Blood sugar was managed with subcutaneous insulin. Patient was discharged after stabilization and negative RT-PCR and was kept on follow-up in the ophthalmological setup. The visual acuity improved gradually, which at 3 months was hand movement, at 9 months it was 636, 624, and at 15 months of follow-up, it recovered to 612 and 69 from PLPR. So discussion, this patient presented with the chief complaint of sudden bilateral vision loss. After thorough examination, both anterior and posterior segments, which were essentially unremarkable, a diagnosis of cortical blindness was made and patient was urgently scanned for a cerebrovascular accident. Patient was then tested positive for COVID-19 and managed accordingly for PCA and diabetes as well. Visual acuity improved gradually and slowly over the period of 1 year. As seen in our patient with pre-existing risk factors and a confirmed diagnosis of COVID-19, thrombotic events occurred which led to devastating visual outcomes secondary to occipital lobe ischemia as evidenced by neuroimaging. Over time, there is clear evidence that thrombi are a major cause of multisystem organ dysfunction in critical cases. Elevated levels of C-reactive protein and D-dimers directs towards a high inflammatory state and abnormalities with the coagulation cascade. Despite this, our patient presented with the cerebrovascular complication in the early stages of his illness. COVID-19 infection has been associated with prothrombotic effects due to virus-induced cytokine storm that can activate and upregulate the coagulation, which triggers the formation of a thrombus that may lead to ophthalmic artery occlusion, central retinal artery occlusion, central retinal vein occlusion, and others. Along with progressive respiratory system involvement, central nervous system has also been reported to be affected due to the affinity of the virus towards the ACE2 receptors that may result in meningitis, encephalitis, or stroke. Also, SARS-CoV-2 can engage the endothelium, increasing the permeability of the blood-brain barrier and leading to encephalopathy, encephalitis, and thrombosis. So in conclusion, I would like to say visual loss during SARS-CoV-19 infection is a rare finding. Despite the low incidence, many cases have been reported in the literature. COVID-19 related thromboembolic events can cause significant functional deficits, which may include debilitating visual loss. Therefore, as ophthalmologists, COVID-19 should be considered in patients who have developed sudden visual loss, as it can be the presenting feature of the infection in some instances. Clinicians should be aware of this uncommon event to help contribute to an interdisciplinary approach to an appropriate management. Thank you.
Thank you. Did you do a repeat field testing when you have a visual recovery?
No, ma'am, the patient denied it actually.
Because the incidence of stroke associated with visual loss was high in the pandemic era.
Yes, ma'am.
But I think it was, I can't say it is an unusual, but it was, we had seen
should
more
have been
common
done.
presentations because mostly the patients were hospitalized for the acute condition, and later when they presented to the ophthalmologist, it was during the pandemic only they developed the thromboembolic episode. So unusual presentation is
Actually, ma'am, all the literature that has shown the visual loss was always came at a later stage of the disease, and the patient was debilitated and hospitalized. Here, the difference was the patient came with the chief complaint of visual loss, and he was in a very early stage of his disease, and there were no other symptoms despite just a mild
so
cough
it
and
was
fever.
the vision loss as a presenting feature of COVID rather than the patient presenting with COVID.
Yes.
Would you rephrase it that way?
Yes.
But there was bilateral or occipital infarct, na?
Yes.
So it could have been a thromboembolic event,
Yes.
then it could have been a basilar artery.
Yes.
Cannot be a bilateral PCA are affected. There was no neurological sign, no brainstem sign.
Yes.
There was no brainstem sign.
No stents. Yes.
Because it cannot be bilateral PCA infarct. Usually it is hypotension or spasm which causes that your PCA infarct bilateral.
Yes, sir.
But
The
here
artery
the
can be-
thromboembolic event, because the frontal hematoma you have shown, and
Yes.
even the infarct, they were asymmetric. I was seeing the imaging.
Yes.
Do you have any MRI report before the incident happened?
No, sir.
No.
Patient did not have any previous history, or as such he was only diabetic, and he had no any past history, so we do not have any reports of the previous medical history.
D-dimer was raised.
Yes.
And what about fibrinogen? Not knowing. Okay.
That was a remarkable recovery for a cardiac.
Yeah.
Yes, sir.
You have a recovery of the visual acuity, but your field defects will be the most telltale evidence of what you have a persisting deficit.
Yes, and we insisted the patient, but the patient did not.
At least a central fields or a confrontation would have had. It's a basic thing. Okay, right. Thank you. Doctor.
Thank you, ma'am.
Oh, कुछ भी anything. You are right. Yeah, and unusual things.
Now we call upon Dr. Venipriya Sigamani to present on 8.5 syndrome. The only ocular movement is the same as angle of mouth.
Good morning, everyone. I'm going to present a case of 8.5 syndrome. The only ocular movement is the same as the angle of mouth. It is a rare pontine neuro-ophthalmologic syndrome, consists of ipsilateral conjugate horizontal gaze palsy, ipsilateral internuclear ophthalmoplegia, and ipsilateral lower motor neuron facial palsy due to the involvement of medial longitudinal fasciculus, pontine paramedian reticular formation, and seventh nerve fascicle. Our case is a 72-year-old male with the complaints of incomplete closure of right eye for the past 3 days. This was his presenting symptom, and complaints of drooping of mouth on the right side for the past 3 days. No complaints of double vision or blurring of vision, no other significant neurological or ocular symptoms. He was a newly diagnosed DM. On examination, general examination was no abnormality detected, and systemic examination was normal. CNS higher mental functions were intact. On ocular examination, head posture, there was a mild head turned to right side. Primary position, the right eye showed 15-degree esotropia, left eye 5 to 10-degree exo. There was a lag of thalmus of 2 mm in right eye with the loss of forehead wrinkling in the right side, loss of nasolabial folds on the right side, and drooping of angle of the mouth on the right side. There was no chin lift. This was the video showing the extraocular movements. So you can see the left eye abducting nystagmus with the right eye -2 adduction deficit, and supraadduction was normal, infraadduction was normal, and right gaze there was no movement. And only movement available was the left eye abducting nystagmus. So this was his extraocular movements. On the right eye, the visual acuity was 612 with pinhole improved to 6.9. Left eye, it was 636 improvement due to immature cataract. Pupil, there was no RAPD, both eyes. And lens, right eye, pseudophakia, left eye, IMC. Fundus, it was normal. There was no evidence of edema or pallor in the both eyes. MRI showed an ill-defined T2 flare hyperintense areas in the right half of the dorsal pons in the region of the facial colliculus, suggestive of infarct. Since the patient had right horizontal gaze palsy with right internuclear ophthalmoplegia and right facial nerve palsy, and which is an element type, with the MRI showing right pons infarct, we came to the diagnosis of right Eintendorff syndrome. Eintendorff syndrome is a constellation of symptoms that occur due to the lesions involving the ipsilateral 6th nerve nucleus with fascicular portion of the 7th nerve and medial longitudinal fasciculus, resulting in a combination of ipsilateral horizontal gaze palsy and element type of facial nerve palsy and ipsilateral internuclear ophthalmoplegia. The most common causes are vascular lesions, demyelination, and rarely due to tumors. And prognosis depends on the etiology, and it usually has a good prognosis. Coming to the anatomical background behind this disease, the horizontal gaze center is situated in the pontine paramedian reticular formation, and is it situated in the, excuse me.
Your time is up, doctor. Actually, you can wind up with your discussion as well as conclusion.
Okay. So Eintendorff syndrome is due to the lesion of MLF, which showed the internuclear ophthalmoplegia, PPR of ipsilateral gaze palsy, and facial nerve fasciculus involvement, resulting in lag of thalmus and angle of mouth deviation. The only ocular movement available will be the contralateral abducting nystagmus with angle of the mouth movement. Conclusion, it is a rare pontine syndrome. A high degree of clinical suspicion should be there because usually it presents with a element type of facial nerve palsy because it will be the most seeing component of the disease. A mandatory extraocular movement testing is a must in all patients with facial nerve palsy to pick up associated gaze palsies. These are my references. Thank you.
Thank you, doctor, for the nice case presentation. It was an interesting case.
Thank
I
you.
have one question for you. Was there any skew deviation?
No, ma'am, there was no skew deviation.
There was no skew deviation. What about the vertical saccades and pursuit?
No, ma'am. Saccades and pursuits were no.
Vertical saccades are usually present here when it is a horizontal. You will tend to have a vertical sometimes and nystagmus in these cases. Okay. Right.
Thank you, ma'am.
We call upon the next author, Dr. Simran Rai Chandani. She is going to present on hyperandrogenism is an early predictor of IIH.
Good morning, everyone. I'm Dr. Simran Rai Chandani, Junior Resident at Srihar, Chennai, and I'll be presenting my study on hyperandrogenism as an early predictor of IIH. So, idiopathic intracranial hypertension, also known as pseudotumor cerebri, occurs mainly in young obese women. There have been numerous studies that associate it with endocrinological abnormalities. The incidence of it is 3.5 per 1 lakh females in the reproductive age group, and the diagnostic criteria of IIH includes all the signs and symptoms that reflect the intracranial pressure, that is papilledema, a documented elevated intracranial pressure with a normal CSF composition, and a normal MRI CT, and no other cause of intracranial hypertension. The polycystic ovarian syndrome (PCOS) includes truncal obesity, menstrual irregularities, hyperandrogenism with signs of it like hirsutism, acne, alopecia, and multiple ovarian follicles on USG. PCOS is characterized by several endocrine abnormalities, including increased conversion of androstenedione to estrone by stromal cells within the adipose tissue. Insulin resistance is also more common in PCOS. So there have been studies that highlight the association between IIH and hormonal abnormalities, including PCOS. So we did a prospective cross-sectional analysis with 89 women of reproductive age group having IIH, and the diagnosis of IIH was confirmed according to the modified Dandy's criteria. A screening questionnaire and anthropometric parameters were filled by all the participating women. The risk factors of PCOS were identified in such women, and a hormonal profiling including FSH, LH, dihydrotestosterone, insulin was checked and compared with the age-matched population. So the data collected was analyzed, and we had evaluated the relation between BMI and the hormonal profile of these patients. The diagnosis of PCOS was made clinically on the basis of NIH criteria, that is the presence of 2 out of the 3 criteria, a clinical with or without biochemical hyperandrogenism, oligo or anovulation, and a polycystic ovarian morphology on USG. And the incidence of PCOS was calculated and compared with the normal age-matched population. So our results were as follows. The mean age of women who participated in the study was over 29 years, and 87% of our cohort was in the overweight or obese category. So a similar study that was done by INET Clean showed a positive correlation of only insulin with BMI, but in our study we found a positive correlation between insulin, prolactin as well as FSH with the BMI. Dihydrotestosterone was found to be higher in over 30% of our participants, and furthermore it was noted that women with younger age of onset of the disease had higher levels of androgens. A significantly higher prevalence of PCOS was found in such women. As the second table shows a positive correlation of FSH, prolactin and insulin with BMI. We noted that over 20% of the women had deranged FSH and LH values, and over 30% had a higher androgen values. 28% of our cohort had high insulin as well. So to conclude, the study clearly showed that there is a linkage between the levels of circulating androgen and an earlier age of onset of IIH. So we can conclude that in women susceptible to the evolution of IIH, an increased circulating androgens might function as a precipitating factor, allowing earlier expression of the disease. This finding is of particular interest since the most common well-defined form of overt hyperandrogenism in obese women, PCOD, may be linked to the pathogenetic mechanism. It emphasizes the necessity to diagnose associating diseases to aid in better management of the patients with IIH, and also addressing PCOS with the treatment of its associated endocrinological abnormalities such as glucose intolerance and hyperandrogenism can actually help us with the treatment of IIH as well. And we can also follow up these patients with the levels of circulating androgens, which can be an aid in to diagnose it earlier and to start the treatment on an earlier basis. Thank you.
Did you have any control group? Because you had taken patients with IIH and you had looked into the hormonal level.
Yes,
did you do a thyroid profile also in these patients?
No, ma'am.
Because your venogram?
No, ma'am.
Because the risk of CVT is going to be higher in cases who are having a hormonal imbalance, but
yes,
because almost most of them, you said they were in the they had oligomenorrhea or maybe they were
yes,
anovulatory. So if you take into consideration, you can see that there is a high incidence of CVT in these patients. Agreed that you have a hormonal imbalance also, but if you would have taken a control group with PCOD without papilledema, maybe you can have a correlation to express that your circulating androgens in this has predisposed to earlier onset of disease compared with the other group.
Yes, ma'am.
So
Yes.
MRI was not done in any patient. What was the criteria of diagnosing IIH in these patients? You would call it IIH, secondary IIH. How can you say? Because as the madam is saying, venous sinus thrombosis. MRI was not done. What was the criteria of diagnosing IIH or BIH in these cases?
Sir, MRI was done, sir. They were
But MRV was not done. MRV or with MRV with contrast was not done.
Yes, MRI was
And the control were not taken. Okay.
Right. Thank you, doctor. I think you can take it as a furthermore with a control group that gives you a better.
It will be a good study.
Yeah.
It lend power to your study.
Because it gives you a more evidence for to substantiate what you are presenting.
Yeah, 89 is a good number. 89 is a good number. You could have had taken, yeah.
Most of these patients have impaired hormonal. I think there was one article with these setup. So I think you could have taken a control group.
Now we call upon Dr. Vidya Dharani to present on pituitary abscess presenting with oculomotor nerve palsy, a rare cause with a rare manifestation.
Good morning. My report is about pituitary abscess presenting with oculomotor third nerve palsy. To introduce, we know pupil involving third nerve palsy is a sign of dangerous diplopia. It is a neuroophthalmic emergency, especially caused by an aneurysm. Other well-established causes include tumors or trauma involving the anterior cavernous sinus. Pituitary abscess is an uncommon clinical entity and has never been reported to present with third nerve palsy. This case report highlights the unusual association of pituitary abscess with third nerve palsy and the critical role of neuroimaging in its identification. My patient is a 41-year-old female, a diabetic and hypertensive since a year. She presented to us with binocular double vision associated with mild headache since 3 days. She also had a history of on and off mild grade fever since a month. Clinical examination, her visual acuity was normal. Pupillary examination showed anisocoria with the left eye pupil being larger. Extramacular assessment showed the right eye was normal. Left eye was a mild limitation of adduction, elevation and depression. Fundus was normal, and please note her fields were absolutely normal. So with this, I had a 41-year-old female with the left pupil involving third nerve palsy, diabetic and hypertensive. So my clinical suspicion at this point was either a space-occupying lesion of the anterior cavernous sinus such as a meningioma or an aneurysm. These are just representative images. But to my surprise, MRI showed a lobulated lesion in the cella, left paracellar and left cavernous sinus, the central non-enhancing necrotic area and a classically enhancing ring. It was around 2.5 mm into 2 centimeters. And they are highly suggestive of a pituitary abscess. Her MRA was normal. So beyond the surprise, the patient had obtained a neurosurgeon's opinion where she was advised endoscopic transvenous drainage, systemic antibiotics, and also antitubercular treatment, as all intracranial abscess in our Indian scenario are considered tuberculosis until unless proven. Moving on to discussion, pituitary abscess are uncommon. Till date, less than 300 cases have been reported globally. They account for less than 1% of all pituitary lesions. 70% of these cases are de novo, but 30% occurs in secondary lesions of pituitary gland, such as the adenoma, craniopharyngioma, and Rathke's cyst. We know that the pituitary abscess have a vague clinical presentation. Signs and symptoms of pituitary hyperfunction, headache, visual disturbances are not uniform in all patients. Thus, clinical diagnosis is extremely difficult. In this case, patient presented with diplopia, mild headache, and with absolutely normal visual fields. We know that MRI is the most effective imaging modality for pituitary lesions. So how does the abscess appear on MRI? It is seen either as a single cystic mass or a partial cystic mass and hypointense on T1 and hyperintense on T2 variant images with a rim enhancement with contrast injection. To conclude, pituitary abscess, though extremely rare, can still occur. It can have a varied and clinical presentation, and definitely neuroimaging plays a crucial role in its identification. Thank you.
Thank you, Vidya, for that wonderful case. I have a question. What was the field effect?
Fields are normal in normal.
Fields were normal. Did you do a 10-2?
I did not do a 10-2.
Yeah, that's also one thing. And your history is itself in the clue for infectious etiology. Was there any culture done for the abscess drainage? What they had done?
She has undergone the procedure. She has yet to come back with her reports. We yet to see that.
Fine. Thank you.
Was she a type 1 diabetic or type 2?
Pardon, sir?
She was a type 1 diabetic or type 2?
Type 2 diabetes mellitus.
Type 2 diabetic,
Yes.
young. Okay.
Any blood investigations done?
Ma'am, the minute we diagnosed with the Victoria abscess, we sent her to the neurosurgeon. There she has been evaluated.
Thank you.
Thank you.
Now we call upon the next speaker, Dr. Saranya, to present her topic on decrypting the mystery of bilateral unreactive pupils.
Good morning. My case report is on decrypting the mystery of bilateral unreactive pupils. A 14-year-old male came to our OPD with complaints of difficulty in seeing bright light for past 1 year. History of difficulty in reading was present. No history of redness or watering of eyes, headache, fever. No history of drug usage. No history of any systemic illness or autoimmune disorders. No history of ocular trauma or ocular surgery. On ophthalmic examination, his vision is 6.6 in right eye. In left eye, 6.12 with glasses improving to 6.6. Near vision was N8 on adding 0.5 D spare, N6 in both eyes. In anterior segment examination, right eye was normal except for the pupil. It was 5 mm not reacting to light and accommodation reflex was absent. Similarly, in left eye, pupil 5 mm not reacting to light and accommodation reflex was absent. Otherwise, anterior segment findings were normal in both eyes and extraocular movements were full in both eyes. Fundus examination was normal in both eyes. Color vision, contrast sensitivity and fields were normal in both eyes. Near point of accommodation was 14 mm and near point of convergence is 9 centimeter. On systemic examination, central nervous system and cardiovascular system were found to be normal. Deep tendon reflexes were elicited and was found to be normal. Blood pressure was normal. On digging into diagnosis, we did a denervation supersensitivity test with dilute pilocarpine 0.125% in a dim light room. Pupillary light reflex was recorded at baseline and at 30 minutes after instilling the drops. Before pilocarpine test, the pupil was 5 mm and not reacting. After pilocarpine test, the pupil was 3 mm and was reacting to light in both eyes. The post-drug effect was near vision was N8 after the drug installation it was N6 and near point of accommodation is 10 centimeter after the drug effect and near point of convergence was 7 centimeter. The diagnostic dilemma was light reflex direct and indirect were absent and on pilocarpine test was positive and near reflex was also absent. As a diagnosis of exclusion, we concluded as the patient was having AD tonic pupil because his accommodation reflex was absent. So Argyll-Robertson pupil was ruled out. There is no use of any drugs. So pharmacological mydriasis was ruled out. And on slit lamp examination, iris was found to be normal. So traumatic mydriasis was ruled out. And the patient had extraocular movements were full in both eyes. So third cranial nerve palsy was ruled out. And the patient was advised to do a detailed neurological workup and serological workup to rule out any associated diseases. MRI was found to be normal and neurological opinion and cardiologist opinion were obtained and was found to be normal. And serological examination does not show any abnormality and he was prescribed best glasses for near vision. AD tonic pupil is a disorder in which there is a parasympathetic denervation of the afflicted pupil resulting in poor light but better tonic near construction, seen mostly in unilateral in 80%.
Doctor, your
and
time is up. Please wind up.
Thank you.
Yeah, please. No, you can wind up, I say. Go to your conclusion or your final one.
This is the flow chart showing the how we came to the conclusion with the anisocoria. We compared with dark and in a bright light room, and we did a slit lamp examination, and we could not find any iris sectoral iris palsy or anything, and we did dilute pilocarpine examination with 0.1%, and we found that the larger pupil constricted, suggesting supersensitivity, which made the conclusion of AD stonic pupil as a diagnosis. These are my references.
Thank you. So this was post any viral infection or anything?
No, ma'am. No history of any fever or in the near past. There was no positive history.
You do get sometimes. Any cough, cold?
No, ma'am. In the past 6 months, he was asymptomatic.
Any travel to any region or something?
No, ma'am. He was a school student. He was going to school every day.
Any physician opinion was obtained?
Yeah, a neurologist, cardiologist, and physician opinion was obtained.
Because we have to rule out the autonomic dysfunction.
Yes, ma'am. It was ruled out.
Okay, thank you, doctor, for the interesting case. Next, we have Dr. Kunjal Gala. Your bell is not very sound because we are looking at that time. Please give a more severe sound. Because yeah, please start. We are running short of time, and they are giving us only 5 minutes to vacate the hall.
Good morning. I'm Dr. Kunjal Gala, second year resident from Arvind Eye Hospital, Chennai. I'll be presenting a case about a far-sighted view of disc edema. So disc edema is an ophthalmoscopic finding with unilateral or bilateral swelling of the optic discs, whereas pseudodisc edema is anomalous elevation without the edema in retinal nerve fiber layers. Some of the causes of the same may need extensive investigations, but there are a few which can be as easy a diagnosis as an refractive error. My patient was a 20-year-old female who had presented to us with headache and vomiting since 2 weeks. There was no history of any associated tinnitus, transient visual obscurations or postural variations, and there was no history of previous episodes. Her vision was 3/60 in both the eyes, improving to 6/24 with a correction of +10 diopters. And her near vision was N12, which was not improving. Her color vision, central fields, pupillary responses were normal, anterior segment was normal. On fundus examination, there was elevation of the disc with blurring of the disc margins. There was no obscuration of the overlying vessels. Her intraocular pressure was 16 and 18 in both the eyes. The patient was then further evaluated for bilateral disc edema. She underwent an MRI, which was normal, and an Humphrey field analysis, which was also normal. We then sent her for B scan, and on B scan, her axial length was 16.79 mm in right eye, 16.55 mm in left eye, and there was an increase in the retinochoroidal thickness. It was 1.29 in the right eye and 1.62 in the left eye, with which we came to a diagnosis of both eyes nanophthalmos, leading to pseudodisc edema. So nanophthalmos is a Greek word derived from the Greek word nano, which means dwarf. It's basically a clinical phenotype in which the anterior and the posterior segments of the eye do not develop to their normal sizes, but there is no associated ocular or systemic anomalies. We can have a short axial length, as we saw in our patient, thickened sclera, small cornea, and a shallow anterior chamber. Coming to disc edema, there are 10 signs of disc edema. There are 5 mechanical and vascular signs which help us identify. Mainly the loss of cup, elevation, blurring of the margins associated with vascular signs which are more commonly seen in true disc edema, which can be venous congestion, hemorrhages, and NFL infarcts. The differential diagnosis can be papilledema or can be other causes of bilateral disc edema without a raised ICT. Hypertensive emergencies, diabetic papillopathy. The other causes of pseudodisc edema, as you can see in the first picture, can be a myopic tilted disc. It can be a congenital anomaly of the optic disc, such as in morning glory syndrome, or even very commonly what we see is an optic disc drusen, which will show a characteristic hyperreflectivity on the B scan. Conclusion, any patient with disc edema needs a systematic approach, and we need to make sure that we keep all our differentials in mind and customize investigations which are needed as per as the patient. Thank you.
Thank you, doctor. Was an OCT done?
No.
Right. You have done an ultrasound. OCT also could have given you a clue. Right.
The B scan, have you measured the ONST? Give a clue.
Okay, right. Thank you, doctor.
Now we call upon the next speaker, Dr. Shadma Iqbal, to present on the OCT in patients of Parkinson's disease.
Is she available? Okay. Now session is over. Thank you.
Thank you.
She's not there.